On this channel, we explore concepts in clinical reasoning and medicine in a simple and systematic way. Let's get started. Now we will discuss about hyperglycemia treatment. The diagram illustrates a comprehensive and patient-centered approach to the use of glucose-lowering medications in the management of type 2 diabetes mellitus, with particular emphasis on cardiovascular protection, kidney protection, weight management, and achievement of glycemic targets. The algorithm reflects modern diabetes management principles recommended by major international guidelines, such as the American Diabetes Association, ADA, and emphasizes that treatment selection should not focus solely on blood glucose reduction, but also on reducing long-term complications, such as cardiovascular disease, heart failure, and chronic kidney disease. At the top of the diagram, the foundation of diabetes care consists of healthy lifestyle behaviors, diabetes self-management education and support, DSMES, and attention to social determinants of health. This highlights that lifestyle modification remains essential regardless of pharmacologic therapy. Patients are encouraged to maintain a healthy diet, engage in regular physical activity, achieve adequate sleep, stop smoking, manage stress, and adhere to medications. Education and social support are important because socioeconomic barriers, health literacy, and psychological conditions significantly affect treatment success. The diagram also emphasizes regular reassessment every 3 to 6 months to avoid therapeutic inertia and to adjust therapy according to disease progression and treatment response. The left side of the algorithm focuses on reduction of cardiovascular and kidney risk. In patients with established atherosclerotic cardiovascular disease, ASCVD, or high cardiovascular risk, the preferred therapies are either GLP-1 receptor agonists with proven cardiovascular benefit or SGLT2 inhibitors with demonstrated cardiovascular protection. These medications not only lower glucose levels, but also reduce major adverse cardiovascular events, such as myocardial infarction, stroke, and cardiovascular death. If glycemic targets remain above goal, combination therapy using both drug classes may be considered for additional protection. For patients with heart failure, especially heart failure with reduced ejection fraction, HFrF, or preserved ejection fraction, HFpEF, SGLT2 inhibitors are strongly recommended because of their proven benefits in reducing hospitalization for heart failure and improving cardiovascular outcomes. The diagram suggests that additional therapy with GLP-1 receptor agonists may be considered in selected patients, especially when obesity or persistent hyperglycemia is present. The kidney disease section specifically addresses chronic kidney disease, CKD, defined by reduced estimated glomerular filtration rate, eGFR, below 60 milliliters per minute per 1.73 square meters, or albuminuria with urine albumin creatinine ratio, ACR, is greater than or equal to 30 milligrams per gram. In patients already receiving maximally tolerated doses of ACE inhibitors or angiotensin receptor blockers, ARBs, SGLT2 inhibitors are recommended as first-line agents because strong evidence demonstrates their ability to slow CKD progression, reduce albuminuria, and delay end-stage kidney disease. These agents may still provide renal protection even when eGFR declines below 45 milliliters per minute per 1.73 square meters, although glycemic effects become less pronounced. GLP-1 receptor agonists with proven kidney benefit are considered an alternative or additional therapy, especially if glycemic control remains inadequate despite SGLT2 inhibitor use. The diagram also highlights management of metabolic-associated steatotic liver disease, MASLD, or metabolic-associated steatohepatitis, MASH, conditions that commonly coexist with type 2 diabetes and obesity. Certain medications, particularly GLP-1 receptor agonists, dual GIP-GLP-1 receptor agonists, and pioglitazone, may provide beneficial effects in reducing liver fat accumulation and improving hepatic inflammation. The right side of the diagram emphasizes achievement and maintenance of glycemic goals and weight management. Weight reduction is increasingly recognized as a major therapeutic target because obesity contributes to insulin resistance, cardiovascular disease, and CKD progression. Medications are categorized according to their efficacy for weight loss. Semaglutide and tirzepatide demonstrate very high efficacy for weight reduction, while agents such as dulaglutide and liraglutide also provide substantial weight loss. In contrast, medications such as DPP-4 inhibitors are considered weight neutral. The chart further classifies medications according to glucose-lowering efficacy. Agents such as high-dose dulaglutide, semaglutide, tirzepatide, insulin combinations, and injectable GLP-1 receptor agonist combinations are considered highly effective for lowering HbA1c. Intermediate efficacy is observed with DPP-4 inhibitors, while metformin remains a foundational therapy because of its effectiveness, safety profile, low hypoglycemia risk, and affordability. An important concept illustrated throughout the diagram is individualized therapy. Treatment selection should consider multiple patient-specific factors, including cardiovascular disease, CKD, heart failure, obesity, hypoglycemia risk, cost, patient preference, tolerability, and access to medications. The algorithm also stresses the importance of avoiding hypoglycemia, especially in elderly individuals and high-risk populations. Overall, the diagram demonstrates the evolution of modern diabetes management from a glucose-centered approach toward a comprehensive cardiorenal metabolic strategy. Current treatment decisions prioritize protection of the heart and kidneys, prevention of long-term complications, weight management, and improvement of overall patient quality of life, rather than focusing exclusively on blood glucose reduction alone. In medicine, treating type 2 diabetes is not only about lowering blood sugar, but about protecting life as a whole. Every decision we make should place the patient at the center, safeguarding the heart, preserving kidney function, managing weight, and achieving healthy glycemic control with compassion and precision. Modern glucose-lowering therapies remind us that true healing goes beyond numbers on a laboratory report. It is about improving quality of life, preventing future complications, and giving patients the opportunity to live longer, healthier, and more meaningful lives. A physician's role is not merely to treat disease, but to guide every patient toward hope, balance, and lasting well-being. Beyond the science of treatment, diabetes care is also a journey of trust, education, and continuity. Each patient carries a unique story, lifestyle, and set of challenges that require individualized care and empathy. The advancement of glucose-lowering medications reflects the progress of modern medicine, where therapies are designed not only to control disease, but also to reduce cardiovascular risk, delay kidney damage, and support healthier living. As future healthcare professionals, we must remember that every prescription represents a commitment to compassion, prevention, and patient-centered care. Through knowledge, innovation, and humanity, we can transform chronic disease management into a pathway toward dignity and hope. We will continue this discussion in Part 2. Thank you, and stay tuned.